So hi everyone, my name's Hussein Ibrahim, and like Laura just said, I'm a doctor and researcher, and I'm currently working as a research fellow in artificial intelligence. And I've been asked to talk to you today about health data and health inequalities. I believe there are two important questions worth exploring when considering health data and health inequalities. Next slide, please. And those two questions are, what's the relationship between health data and health inequalities? And how can we use health data to help decrease health inequalities? Next slide, please. So I believe the best way of exploring these two questions is by revisiting the research that first got me and my team thinking about them in the first place, which is a global review of publicly available ophthalmic imaging datasets. My colleague Saad, as we've said, who's a junior doctor currently working in the Oxford area, is unable to be here today, but is one of the lead researchers on that paper. But he's kindly pre-recorded a presentation outlining the work for us. So we're going to hear from him first and then go through those two questions in turn.
Thank you, Hussein. The routine collection of health data has made possible the evolution of large health datasets, which in turn has accelerated research in the field of digital health. One application which has particularly benefited from this is machine learning, which is a subset of artificial intelligence where the machine or algorithm is trained using data from datasets as indicated by the green dots on the left, and these are then used to generate the required output, as indicated by the yellow dots on the right. This process of training machine learning algorithms highlights the need for careful inspection of the data we use for health data research, as gaps in input data is likely to impact on the generated outputs of such applications, which then calls into question their usability and applicability in the real-world setting. Ophthalmology, being an image-centered specialty, has seen an exponential rise in health data research, where several large imaging datasets like Messidor and IPAX have been used to train data for machine learning models. However, these datasets have not been formally evaluated, so it is currently unknown how many such ophthalmic datasets exist, how accessible they are, the amount of metadata they report, and most importantly, to what degree disease and population groups are represented. In our study, we attempted to find and analyze all publicly available ophthalmic datasets to help us answer these key questions. Our search was conducted on Medline, Google Search, and Google Dataset Search in December 2019. We identified 94 publicly available ophthalmic imaging datasets containing over 500,000 images and 125 videos from at least 122,000 subjects. Beside healthy eyes, the most common diseases represented across datasets were diabetic eye disease, found within 35 datasets, followed by glaucoma, age-related macular degeneration, and hypertensive retinopathy. The regions from where datasets originated included Asia, Middle East, Africa, Europe, North America, and South America, with Asia and Europe having the highest output of 34 datasets each. No datasets were identified from Oceania. For completeness of metadata reporting, basic patient demographics such as ethnicity, gender, and age were reported in only less than 20% of datasets. Our study identified 94 open access datasets for eye imaging, which we have now made visible for the community to use. While some diseases like diabetic retinopathy were commonly seen across datasets, diseases like cataracts and trachoma, which are on the list of World Health Organization priority eye diseases, were sparsely represented. We also found a disparity among the geographical distribution of datasets and the populations represented. Most datasets originated from USA and China. Shockingly, there were no known publicly available datasets for ophthalmic images in 172 countries, which equates to nearly 45% of the global population. Lastly, we found that many datasets do not report basic patient characteristics such as age, gender, and ethnicity, which makes it difficult to assess the degree of representation of these different population subgroups. These gaps in population and disease representation demonstrates what we call health data poverty. This health data poverty, if not addressed, will restrict the extent to which some individuals or even whole populations can benefit from digital health research and contribute to further inequalities in health. I will now hand back over to Hussein, who will talk to you more about the impact of these health inequalities and how these can be addressed.
Thank you, Saad. And like I said, that was the research that first got my team and I thinking about these questions that we're about to explore in the first place. So I think it's a really useful place to start. So back to our two questions. And question one was, what is the relationship between health data and health inequalities? Next slide, please. So in short, it's shaky. The use of health data has the potential to narrow the global health and well-being gap and decrease levels of health inequality, but it's highly possible that the use of health data could increase levels of health inequality instead. So let's consider each of these two outcomes in turn. Next slide, please. So first, how can health data decrease health inequality? So to understand this, you've got to understand how health data is used and what the secondary use of health data is. Now, Saad sort of touched on this before, but I'm going to recap. So the primary or direct use is where health data is used to deliver healthcare to the individual from whom it was collected. Here, health data helps the healthcare professionals when they make diagnoses and decisions relating to an individual's care. For example, when a doctor diagnoses a patient with anemia on the basis of their blood results and decides to arrange further tests to investigate the cause before initiating treatment. The secondary or indirect use is where health data is used to improve healthcare and healthcare services. So here, small amounts of health data relating to lots of different people is pulled together to create large health data sets, which can be used to conduct health data research. And in this way, health data helps to improve our understanding of disease and disability, identify better ways to predict and diagnose illness, develop new treatments and technologies, monitor safety, plan services, and evaluate policies. The secondary use of health data has been instrumental in driving discovery and innovation in the digital age. And these discoveries and innovations in turn are offering us opportunities to decrease the levels of health inequality. So consider, for example, some of the ophthalmic imaging data discussed earlier, fundus photographs. So for those of you who don't know, the fundus is the back of the eye, and it's the part that you see when you look through a person's pupil. Examination of the fundus is a routine aspect of the ophthalmic examination. Signs can be seen on examination of the fundus that help doctors diagnose eye diseases. And photographs of the fundus are often taken to help enable comparison of a patient's condition over time. Datasets of fundus photographs have also been compiled and used to conduct health data research. And an example of a digital health solution that's been developed using datasets of fundus photographs is an artificial intelligence system for screening diabetic eye disease. Now, diabetic eye disease is a common complication of diabetes, which, if uncontrolled, can lead to loss of vision. It's a leading cause of irreversible vision loss worldwide, especially in people of working age and those from low and middle income countries where the global burden of long-term diseases like diabetes is greatest. We know that it's incredibly important to screen people with diabetes for signs of diabetic eye disease. That's because if we identify the signs early enough, then we can initiate appropriate management strategies to stop the disease process from regressing further and prevent it from reaching the point at which vision is functionally impaired. So in places like the UK and the USA, screening programs to detect diabetic eye disease early exist. So here, for example, this involves people with diabetes having annual fundus photographs. The process is labor intensive, requires human graders who need to be trained and undergo regular quality assurance. An artificial intelligence system for screening diabetic eye disease here in the UK offers us a potentially resource efficient alternative to our existing program. Elsewhere, however, in a place without a screening program, an artificial intelligence system for screening diabetic eye disease offers people access to this potentially sight-saving service for the first time. So by creating the conditions in which everyone, everywhere, could potentially have equal access to and outcomes from a site-saving health service, this data-driven digital health technology offers an opportunity to narrow the global health and well-being gap and decrease health inequality. Next slide, please. To understand, conversely, how health data can widen the health and well-being gap and increase health inequality, you've got to understand what data disparities are. And again, Saad's touched on this before, but I'm going to recap. So health data disparities are differences in the quantity and/or quality of health data representing different individuals, groups, or populations. Data disparities have been demonstrated across demographics, disciplines, and diseases. And Saad has neatly described the disparities that we found in publicly available ophthalmic imaging datasets. But they exist elsewhere too. So, for example, it was found that across multiple medical specialties in the USA, artificial intelligence systems for diagnostic imaging tasks were disproportionately trained on image data from California, Massachusetts, and New York, with little to no representation from the remaining 47 states and their populations. And data disparities aren't solely limited to imaging datasets. In genetics, for example, as of 2018, individuals in genome-wide association studies were 78% European, 10% Asian, 2% African, 1% Hispanic, and less than 1% all other ethnic groups. And similarly, the sample of individuals whose data makes up the UK Biobank, which is a major health data resource for health data research, has been shown to be significantly healthier than the general population, with underrepresentation of individuals with socioeconomic deprivation and from certain ethnic backgrounds. It's imbalances like these, incorporated into the datasets that are used to develop digital health technologies, that can, in extreme scenarios, lead to a situation where they're safe and effective for some people, but dangerous and defective for others. And that's because these tools are entirely dependent on the data that's used to develop them, and they may be highly sensitive to fundamental characteristics including age, sex, ethnicity, environment, and potentially many other things. Therefore, people that are underrepresented may be unable to benefit from and may even be harmed by them. So, going back to our ophthalmic example, I previously explained how an artificial intelligence system for screening diabetic eye disease could narrow the global health and well-being gap by creating the conditions in which everyone everywhere had equal access to and outcomes from a site-saving health service. But I didn't explain that this idealized outcome would require the technology to be safe and effective for all individuals, groups, and populations, which would require the data that was used to develop it to be adequately representative. So if, for example, fundus photographs that make up a training dataset are disproportionately derived from people in, say, North America, and this dataset is used to develop an artificial intelligence system for screening diabetic eye disease, it's likely that this technology will perform well in that population, but that it will underperform if deployed elsewhere. So rather than narrowing the global health and well-being gap, the data-driven digital health technology would actually do the opposite. People who already have access to a screening program would be provided with a safe and effective, resource-efficient digital equivalent to their existing program, whereas people without access to such a screening program would potentially be provided with a dangerous and defective digital health solution. Now, my team and I have described the inability for individuals, groups, and populations to benefit from a discovery or innovation due to a lack of data that's adequately representative as health data poverty. And in this example, people underrepresented in the training dataset in whom the artificial intelligence system underperforms could be considered to be health data poor. Now, the problem of health data poverty is that it risks creating a digital health divide, not just around unequal access to the health technologies themselves, but also around unequal representation in the data foundation on which the technologies are dependent. Now, as health data disparities tend to be born out of existing health inequalities, and by that I mean people with less access to high quality healthcare tend to have less health data representing them, health data poverty will actually likely exacerbate and perpetuate existing health inequalities. And it's by this mechanism that health data can widen the health and well-being gap and increase levels of health inequality. Next slide, please. So we've addressed the first question, and now we're going to turn to the second one, which is how can health data be used to help decrease health inequalities? So I've just explained that a data-driven discovery innovation is only likely to perform equitably across populations and groups if it was developed using an adequately representative data set. Next slide, please. So my team and I assert that if we want to maximize the chances that the use of health data will decrease levels of health inequalities, as well as one, highlighting the issue like we're doing here, and two, improving access to the technologies and the literacy in using those technologies across the population, we need to invest in the data foundation on which these digital health technologies are built. Specifically, we need to invest in ensuring that the health data sets are inclusive and representative. So how do we do this? Like, how do we tip the scales in that diagram or picture to the left? Next slide, please. So I'll touch on these in turn. How do we make it more inclusive? Well, health data is a resource, and the source of that resource is citizens. So data-driven discovery and innovation in digital health is dependent on citizens sharing their health data for the purposes of health data research. And by extension, equitable data-driven discovery and innovation in digital health is dependent on citizens who are adequately representative of the wider population in terms of age, sex, ethnicity, and environment, sharing their health data for the purposes of health data research. Therefore, investing in improving involvement in health data research at the level of the citizen is incredibly important. And studies have shown that the more people understand about how their health data is used and what health data research is, the more they're willing to participate. So we need to transparently and effectively communicate to citizens how their health data can directly contribute to making digital health solutions effective, safe, and importantly, equitable. Studies also show that a significant barrier that prevents people from participating in health data research is privacy and confidentiality related concerns. So we need to ensure that all of our research activities are underpinned by effective data governance systems and also transparently and effectively communicate to citizens as to how their data is being protected. This communication clearly needs to be focused towards improving involvement in citizens from the already excluded groups and populations. Next slide, please. Improving involvement in health data research at the level of the citizen through communication campaigns is incredibly important, as I've just said, but it won't lead to improvements in representation in health data sets without additional action. So it's important that we also invest in building these representative health data sets. Now, one option is to build representative health data sets from scratch, and that's a significant investment, and it can't simply be done through opt-in research cohorts. Yes, such cohorts are valuable, but they do, as in our example of the UK Biobank, lead to skewed populations. More representative data sets are instead gathered through the use of routinely collected NHS data. Because health data is generated at every single healthcare encounter, we can use this approach to build representative health data sets with relative ease. HDR UK is committed to unifying the UK's health data to enable discoveries that improve people's lives, and is helping to build such data sets using routinely collected NHS data. And through a number of its research hubs, like Pioneer, the hub for acute care, but also, for example, through Insight, the hub for eye care, is making this data available and research ready. Another option, other than building data sets from scratch, is to enrich existing ones. And so that would involve identifying the existing publicly available health data sets, as Saad did in his study, and then evaluating how representative that data is of the general population, and then adding extra data from underrepresented groups, individuals, and populations as appropriate to make them more representative. Next slide, please. So in summary, we've explored two important questions regarding health data and health inequalities this afternoon. Now, the first question was, what's the relationship between health data and health inequalities? And I explained that health data disparities incorporated into data sets that are used to drive discovery and innovation in digital health can cause health data poverty and create a digital health divide that widens the health and well-being gap and increases levels of inequality. And the second question was, how can we use health data to decrease health inequalities? And I explained in response to that we need to invest in the data foundation on which digital health technology is dependent to ensure that health data sets are inclusive and representative so that they improve equity in digital healthcare. I hope you found the talk insightful and interesting. Thanks for having me and thanks for listening.